Thanks for giving me the chance to talk about this challenging topic. Just one note, in the original program, you may have noticed that it was pneumococcal vaccines, and there was a little bit back and forth between the organizers and me how this should be. I stuck with the original title, and there is another title in the program now, but I think it's going to be more interesting for all of us if we not only talk about pneumococcal vaccines. With that said, my disclosure has already been made. I work for Pfizer. And this is the agenda that I would like to take you through today. So I just want to talk a little bit about the concept of indirect protection. I would like to talk about the burden of disease with a focus on comorbidity. I will talk about the direct effects of vaccines in the elderly. And for the sake of time, I will talk about influenza and pneumococcal vaccines. And then I will go to indirect effects. And hopefully we will have some time for discussion and concluding remarks. So I hope that I can make an argument for the fact that if we only look at direct protection, we only measure the tip of the iceberg, and that we really, when we want to look at the value of adult vaccination, if we want to have a holistic view, we need to look below the waterline and look for indirect effects. So what are indirect effects? Well, first, what are direct effects? That's easy. Vaccine prevents infection. Indirect effects, you can have some events which are in the causal chain of infection, maybe behind infection. And we've talked about this already today, and I'll give you more examples. So it could be that you prevent things other than infection by vaccination. And then you can go to the community level, and then you have herd protection, of course. This is also an indirect effect of vaccination. And I think I don't need to explain the concept of herd protection to this audience. You know it. Basically, it's if you, and this depends on the type of infectious disease that you look at, when you have a certain threshold that you reach with your vaccination program, you will not only prevent disease in the vaccinated, but you will also block the transmission chain and thereby will protect the few people in your population that are not vaccinated. There are lots of examples for this. Measles is the most important one, but I want to draw your attention to the fact that also some newcomers of the vaccines do have herd protection. For example, HPV vaccine. Also, rotavirus vaccine, great data to support herd protection. And, of course, the polysaccharide vaccines and PCV in particular. And influenza, I will show you some data to support this as well. So, again, I said, direct protection is an easy one. What about other events in the causal chain that we may be missing by focusing on our clinical trial only on this? And this could be, for example, and we heard already examples today about this. What about this patient with pneumococcal pneumonia that gets discharged, but he doesn't or she doesn't walk home happily, but they are frail people. They may go to the nursing home with a urinary catheter, get a urinary sepsis, and die of this. Well, could we have prevented this by preventing pneumonia in the first place? Probably. Then there are, and L.J. Tan talked about this, then there are these little bit less related events, such as myocardial infarction, that are in relationship, for example, with influenza infections. Can we prevent this by infection? I will show you some data. And then we have, of course, and you all know this, we have influenza, and influenza is also a predisposition to pneumococcal infection. So if we block the acquisition of influenza, we may also prevent the pneumococcal pneumonia. So this is what I would like to talk about a little today. But there's one note of caution. Many of these things are studied in observational studies. And in observational studies, the problem is, okay, you have the vaccine, you have the infection, and we think this is a causal relationship. But because it's not randomized, the person that is vaccinated, it picks, or she or he picks, the exposure for himself. So the healthcare seeking status or the health status in general governs if the patient gets the vaccine, but also if the patient gets the disease, the infection. And that is a problem, and it is notorious, for example, in influenza observational studies, and there has been a great deal of literature, and I really recommend you to read this by Lisa Jackson, 3 very interesting papers, why many old studies of influenza effectiveness have been confounded, and confounded to a very large degree. So this is one study that they did. They basically took a large HMO database and did one of those studies that you usually do. You do a cohort, and you look at influenza exposure, influenza vaccination exposure, and then later look at, do the patients get influenza or not? And of course, you adjust for the typical confounders. And yes, there was protection against pneumonia. And then they also looked at other outcomes, such as cerebrovascular disease hospitalization. And you could think, well, maybe there's an indirect protection, because also you see a risk reduction. But then they took a very implausible endpoint. I think we all agree influenza vaccination does not protect against fall or injury. And still, you have significant protection. So what's going on here? And the answer is actually quite easy. So in many of these studies, you have a very small proportion of very frail elderly people, or people that are close to dying, and they can't go to the doctor and get the vaccine, or the doctor decides, well, these people shouldn't get the vaccine because they will not really profit from it. So these people will then be, in your cases, they will have trauma, and they are not vaccinated. So the vaccine prevents against vaccination. So we have to be careful if we interpret data from observational studies. That's my note of caution for the next studies. So, burden of disease. We talked about adult burden of disease and vaccine-preventable disease in the elderly, and this is some data from the Netherlands, which I like very much. It's the concept of DALIs, and we've heard about DALIs today before. And what they measured, basically, what is the disability life years lost in the Netherlands 2010 to 2014. And what you can see is that it's really influenza, and it's pneumococcal disease, and the blue bar means it's life years lost. So it's the mortality that drives the DALIs for pneumococcal infection, and it's the non-IPD, the non-bacteremic cases. So if we want to protect against pneumococcal disease, we need to protect against the non-invasive disease. Here are the numbers from the paper underlining the importance that we really need to protect the elderly against pneumococcal infection. Now we have a problem. I think you've seen many data that disease incidence, infection incidence increases with age, with comorbidity, but we also have seen just for herpes, for the zoster vaccine, for example, that vaccine efficacy or effectiveness decreases with age. So what's the net benefit? Does it make sense to vaccinate people with comorbidity? And therefore, I would like to introduce you to a little bit of a different concept, which is don't look at vaccine effectiveness or efficacy, look at the incidence of vaccine-preventable disease. What is it? It is the incidence of your infection in your unvaccinated population times vaccine efficacy. And I've shown you one is going down, one is going up. Let's use some numbers, some real numbers, and do the math. So these are the numbers from the CAPITA trial. And I just want to warn you, CAPITA was not a trial to measure incidence. It was measured way too low, but I'll do it anyway, just for this example. And we had an incidence of vaccine type CUP, first episode, in this 65-plus population without comorbidity, 21 per 100,000. And then we had vaccine efficacy in these healthy 65 plus of 66%. So you can prevent 14 cases per 100,000. Now we do the same math for the population with comorbidity. Here you can see much higher disease incidence, but also lower effectiveness. This is 40%. These are post hoc analyses. They've been shown in scientific meetings. It's not yet published. But what I just want to highlight, if you look at the vaccine-preventable disease incidence, it's more, you maximize the effect of vaccination if you vaccinate the comorbid people. So how frequent are comorbid conditions in the overall population? Well, you can see risk factor seems to be age seems to be a risk factor for comorbidity, and that's no surprise. I didn't need to show you this. But this is UK data. Almost 1/2 of the 65+ people have at least one comorbid illness. And if you look at the top 3, also this is no surprise. It's chronic heart disease, it's chronic respiratory disease, kidney disease, and it's diabetes. So if we want to have a vaccine that has an impact, we need to show that it works in this kind of population. So what about the data on influenza and comorbid illness? Is it a risk factor or not? It's actually, we always talk about these typical comorbid illnesses, that they are risk factors. If you look at the data, it's not so clear. This is a meta-analysis that was published in 2013 that has nicely analyzed this. And if you look at the outcome hospitalization, yes, age, any comorbidity, and the comorbidities outlined, there are risk factors for the risk of hospitalization with influenza. If you look at pneumonia, there's really, you can see that the confidence intervals are overlapping with 1. So it's not so clear, and also for all-cause mortality, it is less clear. Is it because influenza doesn't affect mortality? Probably not, but the studies are not powered. There are different type of definitions for comorbid illness and a number of methods problems, which are probably causing this. But the authors conclude there is only limited evidence overall, and we need better studies. But on the other hand, you read that in most of these meta-analyses. Similar data, but different graph for pneumococcal pneumonia. These are data from the US, which show the risk for pneumococcal pneumonia stratified by age as well as by comorbid illness. And you always have to compare the graphs of the bars with the same color. So take the 65+ population, and then you will see diabetes to the age-match controls has a 2.8 higher risk for contracting pneumococcal pneumonia. And you can see there's a clear hierarchy, and it's the chronic lung diseases, and this is actually something that will over and over you will encounter if you look at the studies. It's the chronic respiratory diseases that carry the highest risk. So I told you that we have to look a little bit at the outcome of vaccine preventable diseases, because we always think patients are healed or patients are dead, but there's a lot in between. And this is a very nice analysis from the Kaiser Permanente cohort, where a colleague of mine actually looked at what type of discharge do patients with invasive pneumococcal disease have, and they're also stratified by age. And you can see, if you just take the +65, you have almost 20% that need assistance after they leave the hospital. They go to nursing homes, and this fraction increases with age. It's 30%. If you look at the age bracket 65 to 79 and above the age of 80, it's 40%. So a lot of people that go home with a lower functional status, which are very frail. What about the more unsuspected associations between vaccine-preventable infections and other outcomes? So here, very nice analysis from the US. This is a cohort that looked at cardiovascular prevention, 6,000 people almost, followed up for 10 years, and they took the CUP cases and matched them to controls, and they matched them for comorbidity, and they adjusted this for cardiovascular risk factors, and looked what's happening in the next 10 years. And there's a large increase in the risk for cardiovascular events after pneumonia. And what the surprising thing in this study was, it's not just in the 30 days after the pneumonia episode. This risk is up to 10 years. You can find it in this cohort. And in this publication, I took it out for reasons of simplicity. This was replicated in a second cohort with similar results. So seems to be association between cardiovascular events and pneumonia. So let's talk about direct effects of vaccination. And again, I will talk a little bit about influenza. And because I told you that there's a lot of that influenza studies are at risk of confounding, I picked a meta-analysis which did really which I think is the best methodology to look at this. They only took test-negative, laboratory-confirmed influenza. So here you can, this test-negative design takes a little bit care by itself of the healthcare seeking behavior of your participants. And here are the data. The overall effectiveness, this was seasonal influenza over several seasons, was 32%. Is this disappointing or not? I think it isn't. I think it is a fair value. It's probably coming close to the reality if there's a good antigen match. But it's also dropping with age. Also, I think this is no surprise. What about comorbidities? That's reassuring. So it looks like if you look at the protection in patients with comorbid illness, we seem to have the same degree of vaccine effectiveness in patients with comorbid illness than without. What about pneumococcal vaccines? I think here I have to step back a little bit. You know that I am a little bit partial here. So we have two vaccines, one polysaccharide vaccine, one conjugate vaccine. What are the differences in features? It's listed in this table. And the main difference is that one vaccine, the conjugate vaccine, has an effect on carriage and mucosal disease. And that will have secondary implications for herd effects. So I have no slide to show for this, but basically the pneumococcal polysaccharide vaccine has no impact on herd immunity, and I think no one would challenge this. What about the polysaccharide vaccine and its impact of pneumococcal pneumonia? We've seen all these data this morning. There's a big debate, many meta-analyses, and many different opinions. I will not go into the data. We've seen them this morning. I just want to show you what do vaccine technical committees make of this very difficult to handle evidence. So we have the Americans. They conclude in their reasoning for their recommendation that it doesn't work against non-bacteremic pneumococcal pneumonia. We have JCVI, which advocates PPV23 vaccination, but they also say that it's unlikely that this vaccine works against pneumonia. And then we have STIKO, which has a very different opinion because STIKO says this is a good vaccine for pneumococcal pneumonia, which has an effectiveness of 64% by their meta-analysis. So I will then go to PPV23 against IPD. We have one meta-analysis from the Cochrane Institute, and I think we've discussed that this meta-analysis has some limitations, but nevertheless, they concluded in patients with comorbid illness, this vaccine doesn't seem to be effective. I told you I like test-negative studies, so I will show you the data from the UK, which have probably the best surveillance system in the world for invasive pneumococcal disease. And they also looked the effectiveness of the PPV23 program they had and stratified by age and by comorbid illness. What did they find? They could show that, yes, it is effective in the above 65, but this is only for up to 2 years, and after that, no protection. So it's protection which is very short-lived. And then we have, of course, the pneumococcal conjugate vaccine. You've seen these data, and I will be rather short to have more time to discuss also indirect protection. We have the CAPITA study. This was the largest vaccine trial ever conducted. It's a randomized controlled clinical trial, PCV13 against placebo. The primary outcome of this proof of concept study was vaccine type pneumococcal cup, and then secondary outcomes was non-bacteremic and invasive disease. What were the results? before I go to the results, I wanted to assure you we had a number of patients which had comorbid illness in this trial, 42% in both groups. So we were powered to really, there was no power calculation, I shouldn't say that, but there were a number of people that you can analyze. So the data, you know them. The overall effectiveness against the primary endpoint was, efficacy I should say, was 46% against the first episode of vaccine type CUP. If you just look at non-bacteremic vaccine type CUP, it was 45%, invasive disease 75%. But these data you may not know. This is our post-hoc analysis where we just looked at the patients that had a self-reported comorbid illness. And here we had an effectiveness in the per protocol analysis of 40%. For the public health purposes, probably looking at the overall pneumococcal CUP is more informative. And here, if you look at the primary endpoint, if you look at this at-risk population, you had comparable efficacy. Herd protection. So the interesting thing, I think we all take it as a given that influenza does have herd protection. But again, if you look at the data, it's not so clear. This is a Eurosurveillance meta-analysis, and it looked at herd protection in the household setting, and you can see large heterogeneity of the studies that they summarize. And the overall effectiveness measure is not significant. But I think there are good reasons to not use household studies to do that, because you have all this interaction with the outside world, which will basically still cause transmission from the outside to household members. So I think the way to go, and lots of people would agree, is to do a cluster randomized trial. And this is basically this study here done by Loeb. And I will explain you why I really like this study, because it's a smart study design. What did they do? They went to the Hutteries. Who are the Hutteries? These are a small community of very Christian people. They live in little communities throughout Canada and the US, 30 to 50 people. They live very remote. They have almost no interaction with the outside world. And then they vaccinated the children in the kindergarten or in the school age, either with influenza or with hepatitis A, and then they measured the laboratory-confirmed influenza in the adults. And here you can see, if you use this very clean methodology, good herd protection, 61% effectiveness to protect non-vaccinated. So this really made me believe, yes, there's herd effect. What about pneumococcal conjugate vaccines? For pneumococcal conjugate vaccines, we have lots of studies, and we could spend the whole day to discuss this. But I was very fortunate because just, I think, 2 weeks ago, this summary appeared in Vaccines, which basically summarizes all the evidence that's out there that the childhood vaccination program protects against invasive pneumococcal disease in adults, as well as pneumonia in adults, here and here. We have only 2 outliers, these 3 studies down here. But if you look at these studies, these are 2 studies from Spain, but this was when they had an uptake of only 40 to 50%. And we know that for pneumococcal vaccines, you need at least an uptake of 70%. And then you have this one study from Uruguay, and I looked at this publication as well, and there seemed to be a little bit of a problem with the surveillance system. They had a moving baseline. So I think overall, the signal is clear. We have herd protection. And we should, if we look at the value of the childhood PCV vaccination program, we have to also consider herd. That adds a lot of value to it. Is there a difference between the different conjugate vaccines in inducing herd immunity or herd protection? We have PCV10, we have PCV13. And just at ECCMID 2 weeks ago, there was this analysis presented from SPITNet, which is a European consortium, which does basically surveillance after a unified protocol. And here, look at these 2 comparisons. These are the indirect effects over time. And you can see this is the PCV10 countries. You see them down here. And you can see that clearly it's going down. It was a significant herd protection. Only in 2015 you have an outlier. But if you look at the same data from the 4 study sites which used either PCV10 alone or they have a mixed program, you don't really see that much of an effect. Why is that so? Well, I would like to draw your attention to these additional serotypes that are in addition to PCV7 in PCV13. And here you can see that PCV13 had a really significant reduction in the non-vaccinated in countries that used PCV13, but in the PCV10 countries, we didn't really see an impact, maybe an increase, hard to say. So my last topic will be, and that's the most difficult one, these intra-individual indirect effects. What are the data for that? Well, this one study, or this one meta-analysis I would like to show you, and this is going back to also what LJ Tan already told you. This is a meta-analysis that looked at the role of influenza vaccination to prevent cardiovascular events. They included 2 types of studies. One was really prevention studies where they took patients with cardiovascular disease and they vaccinated them with influenza vaccine and then looked at myocardial infarct or ischemia. And these trials, in fact, showed protection against cardiovascular events. If you just look at safety data which are collected in vaccine trials, and they also collect then cardiovascular events as a safety event, then you can't show this type of protection, but probably because it's underdiagnosed as a safety event. So it looks like there is some signal, and you have to look closer at this influenza vaccination of patients with cardiovascular disease. My final slide. This is basically the same study methodology looking at the polysaccharide vaccine. Basically, similar idea that can we prevent cardiovascular events in patients by vaccinating with PPV23. 2 large cohort studies, one in Spain with 18,000 patients, one in the US, 80,000 patients, but both failed to show really that there is an impact. Maybe it wasn't the right study methodology, maybe it's not the right vaccine, but it didn't show anything. So I would like to conclude. What about direct effects of a vaccination? I think I hope I could show you that by targeting vaccination at patients with comorbidity, you will maximize your effect, even though the vaccine effectiveness is going down in patients with comorbid illness. I showed you some data from test-negative studies, which are, if you ask an epidemiologist, are the cleanest way to adjust for confounding, that show that the effectiveness varies, but it's between 16 and 30%, depending on the age. I've shown you data from the CAPITA trial, the post-hoc analysis, where we could demonstrate that the effectiveness of PCV13 against the first episode of vaccine type CUP, it's always very complicated, sorry, is 40%. And what I haven't showed you, but I think which is very important to also take into consideration, that this vaccine has effectiveness for 4 years. And I think actually someone today has shown the Kaplan-Meier curves on this. And PPV23, there is protection against IPD, but it looks like it's short-lived in patients with comorbid illness. Indirect effects, the herd protection, we have data for both vaccines, influenza and for pneumococcal conjugate vaccines, that is very convincing. There seemed to be, but I think we need to wait a little bit more, the publication from SPITNet, there seemed to be maybe a difference between the conjugate vaccines in their ability to induce herd immunity, herd protection. And when it comes to the intra-individual indirect effects, and my note of caution, be very careful if you study this. It's easy to do in randomized controlled trials. If we do it in observational studies, we may be just looking at confounding. But I think it's worthwhile pursuing, because if we want to capture the whole value of adult vaccination, we also need to look at indirect effects. And with that said, I'm at the end of my talk, and thank you for listening.
Thank you, Mr. Theilacker, for your very interesting talk and this insight in this very important topic. First insight in this challenge of multimorbidity and vaccination. I'm sure there's the one or the other question that we can allow. Over there, please.
Mel Cohn from MSD Vaccin in Lyon. First, I want to say I'm a little surprised that my colleagues from Pfizer seem to spend an awful lot of time discrediting our product. It's rather remarkable to me. And I think that many of the issues you presented, I don't have time in my question to rebut them one by one, but represent an extremely biased reading of the literature.
Maybe you want to be more to the point. So what do you mean?
I will get to the point.
Okay,
yes, I
great.
will, most certainly. And in particular, numerous times, you all have applied different criteria for PCV than you have for PPV. And you discredited two of the studies that were looking at herd effects by saying, well, you need at least 70% uptake. And yet your colleagues said, well, why isn't there a herd effect for PPV23 when there's no place in the world that has over 70% uptake? So let's apply the same criteria across the board. And similarly,
do you have studies that show PPV23 herd effects? Do you have that data?
Well, let me ask this.
Okay.
Do you have studies showing an impact on carriage in adults for PCV13? In fact, that was looked at by the group that did the capita study, and they were not able to demonstrate an effect. The herd effect from infants is undeniable for PCV13, and we would all agree that PCV is the most useful vaccine, the only vaccine really, to be used in infants. But that's not what we're talking about here. And I think blurring that distinction is part of the challenge.
Just to be clear, I never meant to say that adult vaccination by PCV13 induces herd effects. If I've said that, sorry, I didn't mean it. No.
One more thing also, repeatedly, I think when you compare across studies, you have to compare apples to apples. As was pointed out early today, the issues with diagnosis of non-bacteremic pneumonia are a real challenge. The capita study results that have been repeated several times are for vaccine type cap. By contrast, we don't have a way to look at vaccine type cap for Pneumovax 23. So if you want to compare across studies, let's look at all-cause cap, which is what many of the equivocal studies for Pneumovax 23 use as an outcome, or let's look at pneumococcal pneumonia, all pneumococcal pneumonia, and not just vaccine type. So I think if we really want to look at this critically, the point I'm making is that I think there's another side to this story that isn't getting fully vetted here.
But you have seen that I've showed for pneumococcal cap the results. You have seen that.
I'm sorry?
I have presented the data on pneumococcal cap. And
you presented vaccine type cap.
No, I did not. I showed you the 30% from the protocol analysis.
Fair enough.
Okay.